And I really wanted to stress the fact that I'm extremely happy to stand here in front of you today for this session on our youth's mental health. And there are many people here today, and it goes to show that it is a very important topic for all of us indeed. And it's quite heartening for all of us. It shows what we can do all together for our youth. This session has a very special history. As you know, it was not possible to hold the conference in 2020. In 2021, we were in a tiny room with cameras. There was no audience. And we had our first session on youth mental health. It was a side session in an afternoon. Of course, it was as important as other sessions, but when we looked at the number of logins and the number of downloads of this session's video afterwards, we were very surprised indeed by the popularity for this topic. We were surprised because we were not aware of this before, but also it seems quite legitimate. This popularity seems quite legitimate. What do we owe to our youth? What can we do to help them in terms of physical, mental health, and overall? And of course, mental health was very important during that crisis. We have a very holistic understanding of mental health in Santé Publique France. We follow the WHO definition. I'll try to use it. We'll try to use it during this session. It's a state of well-being in which that enables people to cope with the stresses of life, realize their abilities, learn well and work well, and contribute to their community. And I'm also delighted to facilitate this session with Mrs. Christine Jacob Schumacher, who's agreed to help us. She's the Deputy General Director for Population Health, and of course the DGS, the Director General for Health, is strongly involved in this issue. It's absolutely essential. So thank you very much for being here. Over to you. Thank you very much, Laetitia. Good morning, everybody, here in Paris and to our remote listeners, participants. Indeed, mental health is a major challenge today, and for the Ministry of Health, we were fortunate enough to have the Conference of Psychiatry and Mental Health in 2021. It was a very important moment for shared thinking. The President of the Republic came to close the conference at the end. It might sound like a detail, but it actually shows that there's a lot of political buy-in for this very important topic today. The measures that were defined during this that conference, particularly those that are related to our youth's and children's mental health, so the mental health of our future, were included in the roadmap for mental health and psychiatrics. And it relates to the public policy of the different agencies and ministries, including Santé Publique France, but also the different stakeholders of the French public health system. So this has created a framework, and since 2018 it has guided our action. In these actions we have the launch of the NEB survey, and it's quite interesting to talk about the NEB survey about our youth today, because in the first few minutes you'll have a preview of the results of this survey that will be regularly renewed, and the Ministry of Health is delighted at this. It's also some inter-ministerial work that we want to develop for mental health, because the Ministry of Education and Youth, which is today represented by our colleague Dr. Moltrecht, who will be addressing you later on, this ministry was also involved in NEB. So I'd like to thank the Ministry for Education and Youth for cooperating and for accepting that the NEB survey could be carried out in schools. Children's overall mental health is usually regarded as good. It's an assumption that we make, that we've always made, that we still make, but there are some weak signals that have been mentioned by Laetitia and which we believe are quite concerning, and that we're recording during COVID. Today it's necessary more than ever for decision makers to have data to enlighten their action, and that's why In the next presentations, you will see that this information is very important for decision makers who devise public policies, who build them with stakeholders. We need robust, evidence-based studies in order to make the best decisions for the well-being of our population, irrespective of their age. And the world over, the observation, the fact that we need to act for the mental health of our youth, we have the same findings, and we are delighted to welcome our English colleague Tamsin Ford, who's a specialist in child psychiatry, who works at the Cambridge University, is going to show how our British colleagues started the analysis of their youth, young children's mental health. Thank you very much.
Bonjour à tous.
Hello everybody, I'm sorry, but my French is very limited.
Your beautiful language and speak in English. Apologies. Thank you for the invitation to be here. I'm here to describe a series of epidemiological surveys that have spanned my entire research career and why they have been so important to children's mental health. I was very lucky as a trainee psychiatrist to shadow a scientific advisor in the English Department of Health, and this was in the late 1990s, and we were top of the agenda, and he said, we have maybe 6 months. Well, nearly 25 years later, we're still top of the agenda, and these surveys are part of the reason why. So why bother? If you have good data, you have an idea of how many children are struggling, you have an idea of which segments of your population are struggling, and you have an idea of where they are going for help, so that you might be able to pick them up better. And we have timely interventions for children's mental health. There are things we can do to treat these children. Of course, I'm going to present some statistics from our survey, which are quite frightening, particularly what's happened over the last few years. But we should remember the vast majority of our children are doing okay. There is a vulnerable group who we want to protect and prevent from deteriorating, and then there will always be a population, sadly, with clinical needs, but we want that to be as small as possible. And some examples, which I'll flesh out later, of what these surveys have done, of not only the prevalence data, but the secondary research that has come since. So they are quoted in policy documents all the time. We have demonstrated massive interaction between school and health that has shifted our whole policy a little bit away from health to having school-based mental health teams. We've demonstrated massive costs to the education system of untreated mental health conditions. We can't afford not to support children who have poor mental health. And we've demonstrated by using children in these national surveys as a control group against outcome data that for every £1 that you invest in a school-based mental health team, you save £8 over the next 5 years. We need more of that. It's really important to have high-quality research, and the study you're going to hear about shortly is high-quality research. You can be really proud of what has been done. This link, and I'm making my slides available as a PDF to anyone who wants them, so you don't have to write notes. This was a heroic systematic review of all the mental health research that came out during COVID. When I last checked it, last month, they had screened over 141,000 abstracts. And to get into the first systematic review, which was about changes in mental health, the bar was not high. You had to have a sample frame, you had to use a validated measure, and you had to have at least 2 time points. Not very stringent, and you will see that the number of studies that actually made it over that bar was tiny, and almost none in children. Why do we forget children? They are our future. So the National Survey Programme in Children and Young People started, the first one was in 1999, and it was supposed to be a 5-year rolling programme. 2004 happened, 2009 didn't, but if you remember back to that time, there was a financial crisis, the government didn't have the money. Interestingly, the adult surveys carried on. They spaced out to 7 years instead of 5 years, but they carried on. It took till 2017 and a lot of pressure to get another children's survey. But we got one in 2017. We managed to follow up the original samples for the first two, and in fact the 2017 survey was commissioned to have a 3-year follow-up because it's useful to look at persistence. And then 3 years on from 2020, 2017 and 2020, there was stuff happening that meant we couldn't go out to people's houses and interview, but we have followed this same sample up every year via questionnaire instead. As I've alluded to, methods really matter. You need large samples. If your prevalence is somewhere between 10 and 15%, then if you have a sample of a few hundred, you do not have enough children to study if you want to break things down by different age groups, gender, ethnicity, socioeconomic status. So these studies in the UK were very large. There was a defined sampling frame. Sadly, child benefit was no longer a universal benefit by 2017, so we would have lost our more affluent families, and we had to use a different sampling frame. And then it was a complex survey design, but it was a single phase, so every single child and family had a multi-informant diagnostic assessment, which I'll talk more about. We selected postal sectors, inversely proportional to their size, but when Scotland was involved in the first two, there were people going out to the Highlands and Islands of Scotland in January. I don't think they were best pleased about that, but good data collection. And then within the postal sectors that were selected, we stratified by the age and socioeconomic structure of that population to get a sample that was representative of children in England, Scotland and Wales. The standardised diagnostic assessment we used was called the Development and Wellbeing Assessment, the DORBA, and there's a link to it on one of the slides. And broadly speaking, these were the disorders that we were asking about, the mental health conditions, and I'm not going to go through them in detail, but just so you have a taster. Now, obviously it's quite complicated getting mental health data from children, and what the government asked us to do was to tell them how many children in our population would warrant a specialist mental health service. So we were trying to get back to as close as we could to the best clinical assessment. So parents were interviewed where the child was under 16. Young people were interviewed from the age of 11 upwards. And if the family agreed, for school-aged children, a questionnaire was sent to the school. The measure, the DORBA, combines the best of very structured approaches with the extra validity that you get from a semi-structured approach. So one of my favourite examples of why this is important is a little boy who I had to rate as a clinical rater in the very first survey, who, counting the structured symptoms, the computer thought had a diagnosis of OCD. But when you read the qualitative information about the problem, his mother had misunderstood what we meant by an obsession or a compulsion. And it is if you've got one, they make sense. If you've got mental health training, they make sense. But actually, for the general public, it's a complex construct to get across. And actually this little boy was playing football in the house, and it was causing havoc in the house. It was happening on a daily basis for at least an hour a day. It had gone on for several months. So on the counting symptoms and impairment, he hit the diagnostic criteria, but I think you'll agree he didn't need a psychiatrist. He needed a football team or a garden to go and play football in. So if you have this structured questions that just relate to the diagnostic criteria and then balance it up with the qualitative data, you get the best of both worlds. And we had a small team of clinical raters putting all the information from parents, from teachers, and from young people together. That also allows you to pick up the children who don't quite meet our diagnostic criteria. ICD and DSM are not perfect, but they do allow you not otherwise specified diagnoses. So let's have a look at some of the data. The graph you're looking at in front of you shows 5 to 15-year-olds, which was an age group across all 3 surveys that we had, in 1999, 2004 and 2017. And our children are getting physically healthier, which is fabulous news. But their mental health is deteriorating. And although it doesn't look very dramatic on that graph, it is a statistically significant deterioration. It's a couple of percentage points. And it's almost entirely explained by an increase in anxiety and depression. And in fact, we first saw this in the adult survey in 2004, which was the third in a series using the same methods. Suddenly, 16 to 24-year-old women had an uptick, a massive increase in anxiety, depression, and self-harm. So we've got this signal through two different surveys that seem to be particularly affecting our adolescents and emerging adults. The main surveys are only on children in private households. So we use the same methodology to look at children who were in the care of the local authority. And what you will see is 3 sets of bar graphs. The children who were looked after, so some of them were in secure units, some of them in foster care, some back at home under supervision. So a whole range. The most deprived from the national surveys of children in private households, and the rest of the sample. And that looks like a dose response, doesn't it? And in fact, being a looked after child, which I suspect is an index for adversity, was an independent predictor when you adjusted for everything else. What was so terribly sad is we had almost nothing we could adjust for because these children's histories get lost. Another really important source of information is where children go to help, and in fact this was my PhD, demonstrated that actually only 1/4 of those with impairing mental health conditions in our population survey in 1999 had access specialist mental health provision by 3 years later. And in fact, school staff, teachers, teaching assistants were essentially a frontline mental health service, and they are not trained and supported to do that. That has been a consistent finding over all 3 surveys, and I think you can see here from 2022 from the questionnaire, it's still happening in school-age children. What alarms me slightly is it looks to me from that graph that our emerging adults are less likely to be seeking help, maybe because they're not at school and it's less obvious for them where to go. When I say I'm a child psychiatrist, if people don't take 2 steps backwards and run away, they make a comment about, oh, children don't get mental health problems, do they? I think I've convinced you that some of them do. But the next thing they say is, oh, you know, they grow out of them. So what we did was we took the children who met diagnostic criteria in 1999, 2004 and put them together and tracked them forward to these 3-year follow-ups. Half of those who met diagnostic criteria met in the baseline survey did so 3 years later. These are not transient. So the increasing prevalence that we're detecting in the UK should really worry us, particularly in the light of this excellent work by Stephen Collishaw and his group from Cardiff, which suggests that actually the outcomes for children who struggle are worse in adolescence and adulthood than they were in previous cohorts. He looked at cohorts born in 1970, 1991 and in the millennium. However, diagnosis isn't everything. What you are looking at there is the reports from, on the left, children themselves, The very skewed one on the right is teachers. We should believe teachers when they say there's a problem because they're less likely than other people to score them. And parents in the middle on the strengths and difficulties questionnaire. And the blue arrow is the clinical cut point. Now, there isn't a stark difference. The other thing to be aware of is that parents and teachers are really good at picking out the children who are not struggling. There's a question on the impact scale of the STQ that basically says, do you think this child has a mental health problem? And if the answer to that is no or minor, they almost never have a psychiatric diagnosis. But actually, the prediction of children who are struggling is not so good. Teachers and parents can point out children who are struggling, but they're not good at differentiating what we would call a clinical problem from more minor problems. And that's important for intervention and prevention and screening. So then if we come to the work we've done post-COVID, so as I say, we were due to go back to revisit the 2017 sample in 2020, and COVID happened. So it had to be a questionnaire. We used the Strengths and Difficulties questionnaire because that is an integral part of the diagnostic assessment we used. And there is a computer algorithm that will combine data from whatever informants you have. It will run on one, but it will also run on combining parents and young people and teachers. We didn't have teachers, we just had parents and young people. And it gives a prediction of probable disorder, unlikely or possible. This allowed us to demonstrate to the government the stacking of risks. So a small amount of our population, but that amounts to a lot of children, had no capacity to study remotely, and our schools were closed for quite a long time. And you'll see that, you know, amongst those with a probable disorder, they were less likely to have the access and the equipment they needed to study at home. We demonstrated a sustained deterioration in young people's mental health from about 1 in 9 with probable mental health disorder in 2017 to 1 in 6 over the next few years. And then last year, there was a sudden further deterioration in our older teenagers, which is really worrying. We've collected 2023 data. We've not yet analysed it. In terms of last year, I've mentioned how particularly young women, but certainly the older teenagers, seem to be doing particularly badly. But we're now getting a signal about young boys struggling, which I wonder if the French study will have more to say about. And young women, again, almost a third with probable disorder. That's really worrying. And it's such a key period of life, that emerging adulthood, in terms of all the transitions that you have to make. If you're not functioning well, there are habits and choices that can affect your entire life trajectory, much more than, say, if you got depressed when you were 30 or 40 or 50. The other thing that comes out is the long known, but it can't be said too frequently, association between socioeconomic hardship and mental health. And with the cost of living crisis certainly affecting the UK very badly, I don't know how it's going in France, that means there are going to be more families that are struggling with financial pressures. Finally, I just wanted to mention a bit about eating disorders. So in the UK, we have seen a doubling of emergency and urgent referrals of children with eating disorders, mostly anorexia. And we don't know if this is more health-seeking change or whether it's in the population. Now, we couldn't go out to do the diagnosis. We are now, because of the preparatory work we did, putting the rest of the eating disorders module into the questionnaire, so watch this space. But each DORBA module starts with some screening items. The idea being, if there's absolutely no problem, you don't plough through losing your informant by asking them lots of questions. So we put those because they were used in 2017 into 2021 and 2022. And as you can see, in children and in young people, in boys and in girls, there's been an increase in eating difficulties, not disorder. And it's more marked in girls, all ages, it's more marked in teenagers. However, what does that mean in terms of disorder? The trouble with the screen is it's meant to mop up anybody who might have a problem. So as a clinical screen, it's a bit of a disaster because you'll have lots of false negatives. Well, if we apply the positive predictive value from 2017 to disorder of a positive screen, we get some interesting findings. So overall, it doesn't look like the prevalence has changed, but bear in mind a tiny change in prevalence actually can still swamp services when the condition is not very common, which is what's happening. But there are some hints that something a bit more serious might be going on. So if you look at the boys, for those aged 11 to 16, the prevalence is, the bottom of the confidence interval is where the prevalence was before. And we have a signal in teenage boys that we didn't have before, which I think was probably about who was responding to our invitation to participate. And then again with girls, there could be anything other than like a slight reduction to almost a doubling. So we really need the proper data, and later this year we'll have it. I'm very sorry I can't give it to you. I'll just leave the screening items there in case people are interested, and I will stop and take questions now if there is time. Thank you for your attention.
Merci beaucoup.
Thank you, Professor, for this very interesting presentation that shows us the necessity to have a monitoring system over the long term so as to highlight the very light indicators and to implement public measures. I would like to say hats off to you for all your involvement in everything that you have implemented. That gave a lot of input to our reflections, and we will certainly present the whole work afterwards. But I will give the floor now to the audience to see if there's anyone who would like to ask any question, and then we'll give the floor to our online participants. The first question is always hard to ask. It's always difficult to dare take the floor. There's one here. Please introduce yourself and then ask your question. My name is Angelica Gros. I come from the previous CET. I worked a lot on mental health issues in the past. And I would like to know if your surveys deal in communication, and especially on the double constraint. What about communication within family on this pathology? Do you have data? Is it part of your research?
Thank you. Good question. So, as well as the diagnostic information, we collected a lot of background information about the children, about whether they had special educational needs, for example, whether they had a physical health condition. We also collected details about the parents and who else was in the family. We had a measure of parental mental health, and it won't surprise many of you who've worked with children and families that there is a bi-directional relationship between mental health in children and mental health in parents. It feeds both ways, and it's probably iterative. We had a measure of family functioning. It had to be very brief when we printed out, and in fact the first interview did print out interviews. It was that big, it was huge. We had a little bit of the McMaster's family assessment device that had a couple of questions about communication. in general within the families, we took the decision that these were research assessments, so we didn't feed them back to families because you don't know what you're feeding back into. But we made sure everybody had a list of places they could go to for help if they wished.
Est-ce qu'il y a encore dans la salle quelqu'un?
Do we have anyone else wishing to take the floor and ask a question? And then UNICEF. Hello, Justine Schaeffer from Santé Publique France. Thank you for this wonderful and very interesting presentation. What about the young adults that you followed? Will you have the opportunity to continue go back to them to see how they will feel in a few years down the line?
I think we have a bit of a problem in that these are governmental funded surveys, and one department does surveys that are only supposed to happen twice, and as soon as you go back it's research, and that's another department. So we're kind of stuck because we're not quite one or the other. I think our feeling is that we probably will stop this survey now. It was never set up to be a longitudinal survey. We didn't do any of the things that you would do if you were running a cohort survey, a cohort study, in terms of keeping in touch, making people feel that they're part of something. What we hope to do, though, and we have permission to do, is to link the research data in to administrative data, both health and education. And that is another way that we can follow up these young people to see how they did. Because, you know, our youngest participants in 2017 were 2. There is a lot we could learn from them.
Dernière question dans la salle.
Last question in the audience. Hello.
I would like to ask you a question regarding when you mentioned during the COVID how young people didn't all have access to devices related to internet and have access to school online. But also we have young people who have excess access to internet and social media during that moment. And so how do you cope with that? How do you help the young people who have access to internet, which is a vast space of expression but also of harm that can be done to young people? How can you act on that and protect young people?
That is a really important issue. I think it's one of the... sorry, I can take the headphones off or I'll be distracted. It's one of the things where actually policy needs to run ahead of the evidence because we don't have longitudinal evidence. So with Amy Orban, who is a professor of mental health and social media at Cambridge, we demonstrated that people who were digitally excluded during the pandemic had worse mental health. But there is a correlation, and it's in our survey and others, between poor mental health and using social media more. Because you're measuring both at the same time, you can't tell which is which. And there are definitely websites, you know, promoting anorexia or self-harm as a way of coping, which, you know, you don't need any evidence to suggest that that's actually not helpful. There are bad things that can happen to people online. On the other hand, I think social media is not going anywhere, and we need to think as a society about how we regulate the space. The only space where children are treated the same as adults, and I don't think that's right. I do think we need to think to protect it, and then we do need evidence, but I think we need to act now, and the evidence is going to take years to come. It's a very good question.
Many thanks for your answers and many thanks for the question as well, which was very... there's many other questions coming up on the chat, but we're going to have to close the session, the presentation now.
I can answer them later if helpful, if somebody gets them to me.
That would be nice. Et je pense qu'il y aura aussi beaucoup de questions.
I think there'll be a lot of questions during the break as well, or during the lunch break, because we see a lot of questions coming up on the causes, on the reasons, and there's a lot of debates on that subject. And I'm sure you want to share your information on that subject. Thank you for all your work and all your support to our teams. Thank you very much.
Et j'appelle maintenant Stéphanie Monnier.
I'm asking now Stéphanie Monnier, who's an epidemiologist from Inbeni, who will speak with now. She's in perinatality. She has worked on non-transmissible diseases, non-communicable diseases, and the children's mental health. Hello, everyone. Thank you for giving us the opportunity to present the first results of the NAB survey on the well-being and mental health of children. We'll not talk about it again. This has been recalled brilliantly, also substantiated by Professor Ford. I will explain to you in which context we had the NAB survey. We remember the alerts, the red flags that were triggered on mental health for children and young people, but we didn't have any indicators on the age group from 3 to 11 years old, so we needed to have a sustainable scheme to monitor children's mental health, and this is why we have this study, the objectives of which are the following. First of all, to describe the mental health state and the well-being level of children as a general population in mainland France. We need first the epidemiologic indicators, and then what also is interesting is to improve the knowledge on associated factors, may they be individual or related to the family context or social context. And we also want to look into care that can be provided for mental health issues. Another particularity of this study, it was made in consultation with stakeholders. So first at the design stage, we actually drew upon a group of experts with a steering committee within which we had the Ministry of Health and Prevention and National Education. We also organized a certain number of discussions with the stakeholders coming from three fields, education, and so as to discuss and to see what would be the best conditions to have a successful survey. Of course, these discussions will continue to share the outcomes and to look at the perspectives, the forward-looking outcomes afterwards. As for data collection, so NAB is a transversal survey that actually starts with the kindergarten, middle school. We have a target of 30,000 children. For all the children that participate, the parents were actually needed to fill questionnaires. The teachers would fill a questionnaire on tablet, on a pad for each class, and the children themselves from elementary school, they would fill an interactive questionnaire on the tablets during school time under the supervision of authorized representatives. So this was done in kindergarten, but since they were very young, they weren't filling the questionnaires themselves, obviously. It took place from March to July 2022. So in the next slides, I'm going to show you the methods on which we relied to calculate the mental health indicators. So the first scale that is in the parent-teachers questionnaire is the Strengths and Difficulties questionnaires, the SDQ, based on 25 questions on the strengths and difficulties of the child over the last 6 months or the current school year. So we have 5 dimensions that are being questioned upon, 3 on emotional symptoms, positional symptoms, and hyperactivity. These are actually the indicators that we can use. We also use questions on duration and the impact of the difficulties in the daily life of the child. So to use this scale, we actually apply thresholds that are defined for each scope and for impact, each impact, and that actually enables us to obtain the number of children that cross these very high thresholds, and we can see whether that has an impact or not. So it was a two-stage questionnaire. There was one on the symptoms and another one on well-being. We have a Dominique interactive scale as well. They are based on symptoms at a certain time. And this is what you can see, the examples that you can see on the lower part of the screen. We have 4 related to emotional disorders. 3 for the emotional disorders are specific fears, separation anxiety, generalized anxiety, and depression disorders. And we also have the oppositional disorder. The oppositional defined disorder, and no question is asked on the duration or the impact of the symptoms that are declared. So to operate these data, we gather all the answers that we have collected for each symptoms, and then we apply some thresholds that are defined for each dimension, and we obtain the number of children that have actually reached these very high thresholds. As for the well-being, we use the Kindle-R scale, which is a global scale that actually assesses well-being and life quality, referring back to events that took place during the previous week. So this has actually 6 sub-dimensions of well-being. They were questioned about their physical well-being, emotional self-being, about their self-esteem, about how they felt with their family, with their friends, and at school. And to analyze the scale, we take all the answers, we have a score out of 100, and we can actually calculate a score by sub-dimension. There's no threshold that can define what a good well-being is. So the scores just allow us to define, to follow the children and to see how they feel with one as opposed to another. We gathered the points of view of the different children on mental health from parents but also teachers. We have seen it in literature and clinicians. There were some discrepancies also because some parents and children could see it differently. Some teachers may not share the point of view of the child, and the child may not share the same point of view as their parents. So it's better if we combine and if we cross-cut all the perspectives. So it's important to combine all the points of view, all the different assessments to fine-tune our assessment. How do we do that? So we based ourselves on an English study that is validated, and for this age group that relies upon the integration of teachers and parents' points of view. So we have high symptoms that are taken into consideration as well as the high impact on the life of children. But in NAB, we are lucky because we also ask for the children's point of view, so we decided to take the children's point of view into consideration, especially when the symptoms are high for 2 of the 3 dimensions, like the special phobias, like for depression and so on. Why did we take into consideration the children's point of view? Because the child is a more reliable for that type of dimension than the other dimensions, at least 3 out of 4, so as to reflect a certain level of severity. So we wanted to take these points of view into consideration so as to produce integrated indicators for emotional disorders, for anxiety, for oppositional defined disorders, for anger, for irritability, for vindictive minds, and also ADHD. And the 4th indicator is based on the 3 first ones, which is at least one of these probable disorders. When we say probable, that's important because we have psychometric scales and not clinical scales, so it's a matter of probability that we're taking into consideration when we make our survey. I will now talk about the outcomes. Before getting into the nitty-gritty of the outcomes, one of the quality feedback we had that shows how this survey was actually well endorsed. The children were delighted to take part in this. They liked the way the data was collected, they liked the pads, they liked the way they had to answer questions, and they said they were happy to be given a voice and to be able to speak about that. Children were also satisfied with the class sessions that took place. Participating teachers were very satisfied. 90% said that they were happy, and 53% of teachers thought that the duration of the questionnaire was reasonable. As for the parents who took part, they said they were quite satisfied as well. The fact that they could take part into a mental health survey regarding their children, that was actually well appreciated. So we have 706 children that were randomly picked up, and we have a participation rate that was quite acceptable. 1,357 classes participated. If we take into account the parents who did not want their children to take part, we have 25,000 children that took place, 16,000 of which are in elementary school and 2,000 in kindergarten. So after we cleaned up and brushed off all the data, for our analysis, we had 15,000 questionnaires for children, 15,200 for teachers, and 10,000 for parents, as for elementary school, which is on the left-hand side of the slide. And the analysis that I'm going to show you afterwards actually tackled the whole sample, everything where we have the 3 points of view from children, parents, and teachers. Obviously, this sample is representative of children that are in school after taking the weighing in consideration. As for kindergarten, the participation rate is lower, and we have a bit less than 6,000 questionnaires from teachers and 4,000 from parents. Let's talk about the mental health disorders. When we started our analysis, we started by calculating the indicators without taking into consideration the children's point of view, so as to compare with literature, because the literature used by NAB is very innovative, and we needed these indicators to assess the consistency of our figures, and so we have only one indicator, the probable mental health probability based on the SDQ from parents and children, from parents and teachers. So we mention a European survey based on the same scales with the same informants, and the prevalence was 13%. And we look at the figures from Dr. Ford survey. The scale is 9 to 10% for a probable disorder. And we also have other surveys like the meta-analysis that actually has an outcome of 12.4%. Of course, I will show you our figures that take into account the children's point of view, and we have a prevalence of 5.6% from children that could have a probable emotional disorder. Of course, this is higher because we added an informant. We have 6.6% from oppositional defiant disorders, and from HGHD we have 3.2%. So overall, we have 13% of children that could have at least one probable disorder.
So we continued our analysis by comparing indicators by gender. And you can see in this table that emotional disorders are more frequent amongst girls than boys. 6.6% for emotional disorders, against 4.6, and behavioral disorders are more frequent amongst boys, 3.7% for girls and 9.4% for boys, 1.4% for ADHD for girls, 5% amongst boys. So automatically you have at least one probable disorder which is more frequent amongst boys than girls, 15.3% versus 10.6%. Again, this is consistent with the literature and with known figures. We also conducted our analyses by comparing the different age grades. You can see the different indicators for different ages, but we do not have any demonstration of a significant gap by school level. This result will be fine-tuned using multivariate analysis on the basis of each informant. We also conducted analyses depending on the category of school. We grouped together private and private schools on the one hand, and also high priority, so-called high priority REP and REP plus schools, public schools as well. Again, this result will be fine-tuned with multivariate analysis. One last result on the level of children's well-being. You have a diagram on the left-hand side. So we've compared well-being by gender. In yellow, girls, blue, boys. This diagram shows that the level of well-being, independent of the sub-dimensions, is fairly comparable between boys and girls. We also compared the level of well-being depending on the age, school age or grade. So we have grade 2, 3, 4 in red, grade 5, 6 in green. You can see that there's a difference. We have different dimensions with the little stars. We have the physical score, emotional score, family score, friends-related score. We can see that there's not a real difference as regards the school-related score and self-esteem. I'm done. Just a few words about the limits of our study. As I've said, NEB is the first study of this kind, of this scale in France, that allows us to have representative metrics at national level. Now, the methodological strength is that it's based on 3 points of view. We managed to collect the viewpoints of children. Also that because it was developed in consultation with experts and stakeholders, so members of healthcare, the healthcare system in schools, teachers, etc. Of course, there are different things that we can improve. This is not an exhaustive list, but for the next editions we'll have to try and see how we can improve the participation rate of parents and of nurseries. Of course, we'll have to revise our questionnaires as well, their length, and also we have to translate them. Last, the next steps. Obviously, we'll continue these analyses by analyzing nursery schools data. Also, we'll be looking at all factors related that were collected in parents' questionnaires, and we shall fine-tune those results by looking at the use of mental health care services. We will continue our exchanges with the stakeholders, and as Mrs. Schumacher said, we will extend this to the French overseas territories. The study will be renewed on a regular basis in order to follow over time these metrics. One very last slide. The key takeaways. NEB is a first essential step in the construction of a long-term system. This study was conducted with success, with a great take-up or participation rate of people and a great collective dynamic. 13%, that means at least one child in 8 shows a probable mental health disorder. So this figure shows that mental health is a public health priority and that it's a priority for all. I'd like to seize this opportunity to thank all those who contributed to this study, particularly schools, headmasters, mistresses, schools, school teachers, parents, children, and of course the Ministry of Health, of National Education, members of the different committees. We have the list here on screen. I'll stop it here. Thank you very much indeed.
Alors un immense merci pour
A huge thank you for this presentation. Now, it's always very difficult to grasp from just a few slides what an amazing amount of work you've done in record times. So I suppose when the decision was made to conduct this study, I suppose people were slightly insane by making this decision, because rallying around children, parents, teachers, all stakeholders for a very limited period of time, and they had to complete the study before the summer holidays. Well, you know, I suppose it was quite a bold idea, let's put it this way. And teams have invested a lot of energy within the agency. So did their partners. The Ministry of Education also played the game. And thanks to them, we're sharing these results today. So a huge thank you to all those who contributed to this study. We've just seen the first results. These are the very first results. Others will follow. Now, let's make it different. This time around, we're going to take questions from our remote participants. There's a question about the participation of nursery schools. You mentioned that the participation rate was lower. Do you have any information or figures about this? Also, let me add, do you have any information about parents? Do you understand why parents participated or not? Right. Well, the first potential explanation is probably due to the collection method. We saw that for primary schools, we had sessions in classes, in classrooms with investigators, reviewers who went there, who met children, whereas in nursery schools, parents and teachers simply filled out a questionnaire online. So clearly we must improve our communication method to improve the results. But that's the first potential explanation. Thank you very much. We'll take a question from the auditorium, from the floor. Sorry, it's quite a tight schedule, says the facilitator. I don't know where the microphones are. I think that we have someone there in the center. Also, for the record, someone said that apparently the image on the screen was slightly blurred. Also, for our colleagues who are sitting on the edges, we still have some seats available. If you want, you can come. Hello, my name is Rachel Oss. I work for the health department of the military. Just a question about the random selection. Did you take into account the so-called IPS score for children, something that you hear a lot about when your children are at the end of junior high school? So did you take into account this so-called IPS score? Was there any weighting involved? Right, I'm not sure that this specific metric was taken into account. We had different categories, public, private schools, and so-called higher priority schools, REP or REP+. For this first edition, we tried to take into account a number of parameters by age grade, by type of school. It was a very limited, very restrictive random selection. Actually, we could not take into account regional aspects, so very restrictive selection, particularly given the size of the sample. But that's an avenue for the next edition, and I do hope that my colleagues in charge of the random selection can bear me out on this, but I cannot confirm that this indicator was taken into account. But we did have a number of things that were useful for the weighting of the different metrics. For example, the SES, the socioeconomic status, that was factored in. Thank you very much. Unfortunately, Laetitia and myself are the timekeepers, so if we still have questions in the auditorium, I suggest you ask our speakers over lunch. Let's now move on to the third presentation, and I'd like the representatives of the UNICEF, of the SAMU Social, to come on stage. We are delighted to welcome several speakers, Sarah Ben-Smida, who is in charge of advocacy work at UNICEF, Mrs. Julie Lignon, who is also in charge of an advocacy program for the protection of children at UNICEF France, and Lison Rambière, who works for the social emergency services, the watchdog of the social emergency services, the SAMU Social in Paris. So this will be a three-person presentation. So please make it quick, try to summarize to make sure we have time left for Q&As. Thank you very much indeed. Thank you very much. Greetings to all. So for this presentation of the Growing Up Without a Home report, Grandir sans chez soi, this report was published on the Extreme Poverty Day on the 17th of October. It was amended by UNICEF France and by the Social Emergency Services of Paris, the SAMU Social. Now, of course, mental health is a public health challenge, but there's also right attached to it, as you can see in the International Convention of the Rights of Children. State parties to this convention undertake to recognize for each child the right to enjoy the highest attainable standard of health and to have access to facilities. Now, the issue of mental health today obviously is related to the urgency to meet growing needs. And it was also the subject matter of the report on the situation of children as selected, the theme selected by UNICEF International in 2021, which proposed an analysis of mental health, of children's mental health, which underscored the urgent needs and the lack of resources to meet those needs, and also the need to offer a cross-sectoral approach. So, mental health is part and parcel of healthcare. If you look at the WHO's definition, health is a state of complete physical, mental and social well-being. So you cannot talk about health without talking about mental health. You can first look at the issue of well-being for children. So what are the interactions that children may have? And when disorders occur over time, these may have an impact on their everyday lives. Also, the environments may have an impact. The very close environment, for example, their close relatives, their families. Also, the intermediary environment, for example, the school system, and an environment which is regarded as a more external one, but where you can have wider social determinants, for example, living in poverty or having to deal with pandemics, being discriminated against. So external factors that will also obviously have an impact on children's mental health. Now, in terms of mental health disorder amongst children, the most common disorders observed are anxiety, social withdrawal, behavioral disorders, eating disorders, or even sleep disorders. Today, if you look at the epidemiological context, you can see that there's little data. Now, it's easy to say this after the presentation of the NAB study results, but when we conducted this study, there was very little data available at the time. However, by using modeling, one can assess that 2% of children under 5 have mental health disorder, 12% of children aged between 5 and 9, and 20% of children over 10. Now, the risk factors of risk of depression amongst children. These factors can be, for example, exposure to violence, war, situations like the pandemic, but also an experience of migration, or living in poverty, or being homeless. And this was really the focus of our work here. As Sarah has just said, for some children, their all environments are affected by accumulated risks that cause some vulnerability, particularly homeless children. And we wanted to focus on this population. So we've used the definition of the National Statistic of National Institute of Economic Studies. So homeless people are people who have at least used once temporary services or temporary accommodation services, or who have slept rough, or have used in makeshift shelters the night before. Now, in the last years, we've seen growing difficulties to access to housing, which inevitably translates into a rise in the number of homeless people. Recently, the Abbé Pierre Foundation assessed that between 2012 and 2022, homeless population moved up by 130%. And today, there's a growing number of children in this population. According to the National Institute of Economic Surveys and Statistics, the INSEE, the number of homeless children went up 85% between 2001 and 2012. Recently, it was reported that 42,000 children were homeless, so 41,098 children lived in temporary accommodation, 29,000 lived in hotels. So you can see here a chart which clearly shows this rise. So there's a rise in the number of homeless children, and housing has been recognized by the WHO, amongst others, as a determinant of mental health, and older studies shown a particular vulnerability of children with mental health. So with this report, we wanted to highlight the consequences of a lack of a home on the mental health of children. And Grandir sans chez soi, the title of this report, Growing Up Without a Home, which is part of our advocacy work, also includes recommendations for public authorities to strengthen and adapt public policies for access to housing and to healthcare. In order to write this report, we used several methods. First, we conducted interviews with professionals of mental health. Also, in order to have children participate, we conducted consultations with 9 children aged 9 to 14 who were accommodated by the SAMU Social of Paris. We also recovered data from the French Medical Association. So we had data from some French pediatrics. We looked at literature, studies by associations, but also by the medical community. There's one particular study, the MFAMS, which stands for Children and Family Without a Home. It was carried out between January and May 2013. There are 3 levels for the sampling, the structure, the bedroom, and children. So it gives us a prevalence of mental disorders amongst homeless children. A few results of the NFAMS study. First, about mothers. We know that the health condition of mothers has a stronger impact on children. We can see that their health condition, health status is very deteriorated. We can see that 28.8% of mothers show high prevalence of very clear depression, 80.9% of post-traumatic stress. Also, when we use the SDQ questionnaires with parents, we can see that 90.2% of children show a range of suspected general mental disorders by adding up all scores, and 25.3% show internalized symptoms of impaired mental health by using the Dominic interactive tool. The factors that were associated with deterioration of mental health with higher scores were due, amongst others, to the undocumented status of parents, the fact that parents and children had to share beds. It was more due to small homes, small accommodation rather than the personal choices of parents. Also, recent admissions to hospital and bullying at school. We're now going to present the findings of this report. How does the lack of home affect children's mental health? So this can lead to low material living standards, for example, lack of different facilities. These living conditions can be degrading and can lead to anxiety and low self-esteem. Also, it can mean that it's impossible to meet basic needs such as sleep, food, and hygiene, which has a considerable impact on the mental development of children. Also, these living conditions may lead to a number of conditions that can create a high mental burden and create stress. Physical and mental health conditions are closely interrelated. Also, the lack of a home, and particularly the experience of living on the street, deprives children of a stable and protective environment, which exposes them to many dangers, violence, trafficking also, which can lead to prostitution, but also they can be forced to commit offences, and also we have addictions. Also, in this report, we particularly underscored the specific vulnerability of unaccompanied minors, migrant children, who end up in situations of extreme poverty. These minors are extremely vulnerable, and many of them develop what we call disorders in reaction to insecurity or instability, which deprives them of the required stability for the development of their mental personality. Now, housing is not only about a shelter, it also provides basic needs that organize the lives of people and that affects their health status. So this does have an impact on the family environment, the school environment, and the education of the children, the social environment, and the impact on friends. This can have risks for their mental health. For example, the lack of a home can destabilize the functioning of the family. It can disrupt parent-children interactions and the family roles. We've also underscored the obstacles for children to have access to school, to have continuous education, or to benefit from proper conditions, learning conditions. We know that schools for these homeless children could be a source of stability. Or last, the lack of a home can lead to stigmatization, discrimination, and potentially to self-exclusion, because children are afraid of the judgment of others. Today, there's a growing recognition of that well-being is a public health challenge. This is recognized by health professionals, but also by decision makers. We can see that there has been a rise in the number of patients diagnosed with mental disorders, a rise by 60% of patients who've been monitored in child psychiatric services in the last 20 years. And this was particularly highlighted by COVID. Unfortunately, there's very little data, so it's very difficult to to make any findings on the actual increase of the mental health disorder prevalence in child population in the last decade. Besides, there's a drastic drop in the number of doctors who are qualified for child pediatrics. You can see that we had 3,113 active doctors in 2010 against 2,039 who practiced in 2022. That's a drop of more than one-third of the total health count. Besides, there are regional inequalities on the French territory, which makes access to mental health disorder or mental health care very difficult for children, particularly in the Loire-Cher, where there's no active doctor for child pediatrics. This situation doesn't seem like the situation is improving, as the healthcare offer is mainly based on doctors, it's mainly retired doctors. In 2022, one-third, 36.4% of active doctors in child pediatrics were pensioners who were still working. The average age as at the 1st of January 2022 was 64 for professionals who were still in practice and 56 for regular active professionals. So it doesn't look that this situation is going to improve in the coming years. We can see also that there's a lack of access to healthcare for the overall population, but there are more difficulties for homeless children. Indeed, the residential instability of homeless children is not only a source of stress, but also a factor that leads to discontinuities in treatment. This instability creates a discontinuity in the mental health care pathway, an extension of already very long waiting times. Which can lead to a real separation from the healthcare system, which will particularly weaken children. Dr. Perret explains that residential instability is a double penalty for children who show mental health disorders. Indeed, if you look at the example of children who suffer from neurodevelopmental disorders, the child will already be very sensitive to changes, even the smallest one. The fact that children have to change their living environments very often on a recurrent basis deteriorates their well-being. So treatment for psychiatrics happens in different environments, in public hospitals, or so-called CMPPs. This is fully covered by the French health insurance, but the treatment times of you have very long waiting times. Also in A&Es. Also you have private practices, child psychiatrists, where the fees are very high, and of course homeless families cannot pay for these expenses. And we know that a visit at the therapist costs on average 60 euros. Most of the time it's not reimbursed, so it's very difficult to access these services for these populations. Also, we know that prevention is absolutely essential to improve the well-being of these populations. Particularly, Professor Bruno Falissa says, I quote, that primary prevention is essential. Primary prevention is not part of medicine. It consists in fighting violence, insecurity and exclusion. It's all about public policy, and it's essential. This prevention could be provided by several organizations, for example, the Child and Maternal Protection Systems, the PMI, that's organizations that have developed know-how and skills to receive and support vulnerable families, particularly due to its triple accessibility. But it's a sector which is really saturated today, which is stretched, and it's very difficult for it to fulfill its missions. For homeless children, school can also be a great source of stability, particularly thanks to the healthcare system in schools, but it's also stretched. The last way you can do prevention is reach-out work, something that the SAMU Social, the social emergency services, provides. Like Mélanie Calloch said, reach-out allows the identification of people who need care because they won't come forward spontaneously. Then you can use them, you can help them. The presence of mediators and interpreters in the language of origin is very important. People will then be able to access to care services, the services they need, and they will be referred even before the required treatment.
So in terms of public policies, to answer to this, what we can see is that public policies, mainly in terms of housing but also mental health, are insufficient and also work in silos, and they cannot cover the needs as mentioned, may it be in terms of housing policies, access to housings, which is only a short-term emergency policy, but also for long-term mental health, it is insufficient, and they do not factor in the specific needs of the most vulnerable children, such as homeless children. And so within this report, what we have decided to take into granted is what is to promote the mental health of homeless children by giving them a stable environment conducing to their development, well-being, and exercise of their rights, to improve the prevention and detection of children's mental health problems. We have talked about the direct consequences on their life, but also to improve prevention, but also detection of children's mental health problems by strengthening existing drivers such as school medicine, but we should also better care for the mental health problems of children, all children, by improving the quality of services and taking into account their specific needs. That's everything that relates to strengthening child psychiatrics, for instance. And all this should be done in a cross-disciplinary vision. We should promote transversality with housing, accommodation, mental health, because this is an important condition to have a good mental health for children, but also to make sure that their basic rights are actually satisfied. Thank you for your help, thank you for your attention, and I'm all willing to answer any questions you might have. Thank you for this presentation. With this three-lady presentation with a lot of food for thought. Thank you very much.
parole tout d'abord à la salle pour des questions.
Let's give the floor to the audience for any question.
Oui, bonjour.
Hello, Yves Buisson. I worked on child satanism for many years, a few years ago. What I actually saw, may it be for the housing or professionals of public policies, they were facing difficulties, they felt powerless. They could not help families, and the families had to bear with it. It's quite paradoxical. They had actually additional constraints and they had to bear with all this. Do we still have the same situation? Or is this boomerang effect on families still in existence or not? I would like to know. It is true on social work, but also medical social work, we feel powerless when facing these growing difficulties. We can see it with the current figures in terms of housing. When we see a lack of access to housing, when we see also the housing the lack of housing, the lack of schooling. I'm not the best place to qualify to speak about this, but we can see that there's many people feel powerless, feel that what they do is meaningless. And it's legitimate that families feel left out, excluded, and that contributes to the lack of social bonds. We need to give more value to that. We need to also highlight the importance of social workers, because this helps also to fight against this situation. This is why in our report we highlight the importance of cross-transversality. We need to work with the housing, the health, the school systems. We cannot act on one without working on the others. And we need to reach our goal, we need to work on everything at once. Another question? I would like to know if among your recommendations you included to make an experiment on a basic income, as was done in Canada. The BINCOM survey conducted by Evelyne Forget showed that there was an influence on mental health improvement thanks to that. On a basic income, you mean a basic minimum wage? At the UNICEF level, we're not working on the monetary part, but rather on the multidimensional and the consequences that it can have on the rights of children. So that's not part and parcel of our recommendations, because they focus more on housing and high-quality housing, provisional housing pending a stable one. Of course, lack of income is an obstacle, is an impediment. I know that's the case of other associations who are working on this, and there are also other observatories that are working on this. As for Île-de-France, the main impediment is not money, but administrative red tape. For Île-de-France, we would like to make it easier from a red tape point of view rather than from a monetary point of view, from a money point of view. That would make things easier. That would make things easier. Question? Hello? Is the report online? Can we actually read it? Could we have an answer to the question as to the following question? Are we talking about the different regions of France in your report? Because there are some similarities and differences, maybe from one region to another. As in terms of figures for the housing problems, that's actually that relates to France at large. However, I'm giving you the floor maybe on the figures. As for ANFAM data, they relate to Île-de-France. So we work on Île-de-France population. We don't have other surveys on mental health, on children's mental health in mainland France at large or overseas. That would be very interesting to have such surveys, especially from 2013. I'm sure there have been a lot of developments, but currently we do not have the data to investigate these issues. And since we know that it depends on the region, exclusion from housing is not the same, precariousness is not the same from one place to another. And so to answer your question on the report, it is available online on the social SAMU and also on UNICEF website. You have the full report. So we'll wrap up this first part to have a round table, what I understand from this presentation. First of all, I would like to thank you all for your wonderful presentations. We saw how interesting it was to have assessments. We draw upon the English survey because historically they give us a lot of information, and the NAB survey as well, but also the work that was carried out by some individual associations. We all talked about the social issues. We also see multi-sectorial issues that are highlighted, and the importance of this energy that you put into all of this so as not to be overwhelmed by this daunting task of trying to help and improve mental health so that we can all move forward together. And I'll give the floor to Jacqueline Jacob-Schumacher to wrap up. Thank you. I would also like to thank you, all of you, for your presentations, but also for all the work and service carried out upstream with indicators, scientific data that flesh out all the outcomes, and that gives us actually a guiding lines for public policies. Everything that we've heard, and especially the most recent data with the NAB survey, will be used by the Public Health Ministry, but also Prevention Ministry, but also for a meeting called Les Assises de Santé de l'Enfant. These are concrete examples that actually give us food for thought and substantiate our reflections for the future. Thank you. We will now have a roundtable format.
Merci beaucoup. Donc en 2021, il y avait eu cette session.
So in 2021, we had a session on mental health, and we are reproducing the same format. And we also had a roundtable with the same stakeholders as we had 2 years ago, so we can share together the developments. What have we done in the meantime? What we still want to do? What is ahead of us? What has happened during this period of time that was extremely important in terms of children's mental health? We'll give the floor to the same people. Some individuals have changed, of course, because we also have some turnover in the associations. But I'm going to give the floor to Jacqueline Rioux, who will give us some background information. As was mentioned earlier at the beginning of the session, the COVID pandemic has had an impact that was well described by literature and Santé Publique France publications on children and young people, but the syndromic monitoring systems show that the mental health status of teenagers remains at levels that are really worrying, that are of concern. And this is actually a collective challenge now to try to understand why our young people have such mental health issues and such deteriorated well-being. Several venues for thought have been showed. May it be climate change, geopolitical change, financial difficulties, or the fact that they could speak more freely. But beyond these elements that we need to understand and that will be discussed during the round table, it is necessary to identify solutions. And so we will have some people who will share their grassroots actions and explain how their institutions offer solutions to solutions to the young people in France. Please join us on the podium. So, with me, I have Muriel Cortot-Magal, who is the General Director of the Parents' School Île-de-France, Fil Santé Jeune, Vigile Moltrecht, who's Director he's a General Director of School at the Ministry of National Education, Youth and Sports, Jacques-Caroline Toureau, who's the National Observatory of Protection of Children. Then we have Richard Delorme, professor, who's a child psychiatrist, who's at the Center of Excellence for Autism and Neurodevelopmental Disorders. And then we have Paul Jacquin, who's a doctor. He's a teenager doctor, and he's the director of the Maison des Adolescents Robert Debray and the president of the French Society for the Health of Teenagers. During this round table, we will try to answer three questions. First of all, one regarding the taking stock of the situation and the reasons that you identify that could explain these difficulties as encountered by children and teenagers. Then, in the second part, we will wonder and we will delve into the actions and measures that you implement. And third, last but not least, how do the young people deal with this? How do they tackle this issue of mental health? How do they see things? And at the end of this roundtable, we are fortunate because we will have two young people, Soraya and Aïssata. They are elected from the UNICEF Council, and for 2 years during their term of office, they have thought about mental health. They have made reflections on this, and they decided to establish a prevention campaign on mental health that they will present. So without much further ado, I will give the floor to you all for the first question, namely, taking stock of the situation. What is the situation and the reasons that underpin the situation? And I will give the floor to Muriel Cortot-Magal from Fil Santé Jeune, the hotline for young people. Fil Santé Jeune, what we could see on chats, but also the tools that I will show you later, The age group between 12 and 25 years deals mainly with their personal problems, with their lack of well-being, and that has actually increased over the last years. There are 6 issues that are being outlined from what the young people have said in 2003. First of all, their body and their sexuality. What is normal? What is normality? There's also legal problems. What about addictions? What about screens as well? And excess exposure to social media. And today they're asking about deep lack of well-being and suicidal thoughts. We have different opinions, different feedback, especially from the youngest ones, from 12 to 14 years of age, maybe for girls and boys, actually. Fil Santé Jeune is recognized as a venue where they can talk about their sexuality, where they can speak freely and not being judged. They talk about puberty, they talk about body changes, about skin problems, about voice changes during teenagehood. We know that it's a very sensitive phase, especially in terms of weaving social bonds. The report, the relationship with others, this is actually something that comes up again and again when they speak with others. For 2 years, it has been at the forefront of teenagers' concerns. When they're about 15 years old, they talk a lot about suffering, mental suffering, and it is difficult for them to have sound and kind interpersonal contacts. Often they are actually excluded from their family, and on chats, when they call or in emails, they talk about their doubts, their anger, their fears, their questions relating to complex situations on the family level, on their relationships with their friends or love relationship. Very often they feel isolated, they feel lonely, they feel rejected, they feel despair, and it is difficult for them to tackle these issues with their close relatives. I took a few examples that I'm going to show you. Everything is anonymous, obviously. There's an 18-year-old girl. She was crying online. She said that she was exhausted. She's in terminale, in the last year of high school, that things didn't go well with her friends. They didn't bear listening to her complaining on and on, that the parents didn't help her. Her marks were actually going downwards. And with the psychologist and the people in charge, it seems that she was actually about to drop out from social relationships in general. However, she wishes to integrate a political science curriculum, but she had 14 out of 20 at one test. And she realizes slowly but surely that everything that she says to the others is much too burdensome for the others. We also have a 17-year-old boy, let's call him Rémi. He's got a lot of pressure because he's afraid of living paranoia. He has the impression that everybody's looking at him. He feels observed, even when he's on his own. His malaise comes slowly but surely, and he feels pressure. He feels anxiety 24/7, especially from his close relatives. And he talks about his anxiety, the fact that he smokes cannabis on a regular basis. He smoked before, but he felt bad, especially afterwards. Eddie, 15 years old, has relationship problems with his friends, but he says that he had a lot of friends, but he feels lack of comfort, nausea, or heat whenever he's in presence of the others. And this is why he wants to isolate himself, and he doesn't understand it. And then, as a wrap-up for this small chapter, we found out that the young people need to meet with adults or professionals. They want to be listened to, and they want to trigger something. They want to make sure that loneliness is over. And they can't share it with their family or friends currently, right now. They don't want to feel judged, and they want an answer that is actually living in the moment and not looking forward to the future. And that is a good report on the young people's situation, on their concerns. I'm giving the floor now to Paul Jacquin, who's a child doctor. Hello. Hello, everyone. I won't surprise anyone when I say that we see more and more young people at the Maison des Adolescents suffering from mental disorders, and they are much more serious than they used to be in the past. It's just the situation as we see it in our maison, but also in others, because it's actually widespread over France as a whole. They have suicidal thoughts that are very pregnant. They self-harm. They do self-harm. They have anxiety disorders, school phobia. They drop out, school dropout as well. They also have a lot of eating disorders. As a child doctor, I'm more attentive to this. I see it more in a systematic way. But I see it everywhere. And all the mental health structures have seen that the eating disorders have actually increased twofold. 100% of increase is a lot. We have bulimia and alphalgia with atypical circles. We don't have the anorexia as we used to it. It's much more widespread than it used to be, with associated disorders. We can have depressions, we have eating disorders, and we're quite surprised. The lockdown has played an important role, because people were stuck at home without any physical exercise. All those that were vulnerable in terms of eating disorders or image of their body, or all those that had obesity problems took on weight. The others that were suffering from ADHD, they would actually turn at the tipping point and delve into more suffering. Very often we have domestic abuse, we have abuse at large, not only family abuse. There's also a lot of harassment in a lot of deprived neighborhoods, but also everywhere. Family destructuring as well. That is actually a social indicator that is important, but we have a lot of violence, a lot of abuse that we have seen. And this has actually increased threefold over the last years. Why? Why have teenagers weakened from a mental point of view, from a mental health point of view? There's something that is actually part and parcel of the society. The fact that they are much more individual, extremely individual. They can define as they want. They can recreate themselves, reinvent themselves online. It's wonderful. That can be widespread to 1,000 copies. But if then it collapses, we lose an identity. And there's a loss of a collective identity to the benefit of this individual avatar. And then the context. The context is the one that everybody knows. Anxiety, war in Ukraine, climate change, a world which is very pessimistic that we as adults, we convey everywhere. And together with that, we don't know where we're going. And the adults don't know, or they're afraid to do something wrong, so they don't do anything. They're afraid to be too violent, not to understand, not to be loved by their children. So we feel we can see powerlessness and lack of understanding, and they let the teenagers on their own, and this actually makes them even weaker and more vulnerable. Thank you, Dr. Jacquin. So we can actually keep in mind what has been shown in England. You meet with a lot of children suffering from eating disorders or eating difficulties, and this is very important, and we should keep that in mind and monitor that in our monitoring systems. I will now give the floor to Professor Delorme, who's a pedopsychiatrist. What can I say about that subject? I share your vision. I see that you're all here. There's a lot of enthusiasm on this subject. And this is the most important thing for me today. What is going on around these issues? Politically, how can we actually have skin in the game? When the survey was instigated, we saw how much the suicidal attempts had actually increased, especially for the under 15 years old. I'm a doctor at the emergency, the ER, and we saw a lot of young boys and girls trying to commit suicide. It's not new, but it has sped up. And I think that this ramping of suicidal attempts has shown it in the investigation. There's a strong vulnerability amidst the young children, the under 15 and under 13. And there's also some concern for the young adults, teenagers. Who are they? These young that go to the ER. There's a lot of information that's very important. The population is younger and younger, and there's a lot of girls. 80% of suicidal attempts is actually young girls. There's an age which seems to be more and more critical. We see children that are in the age group 8 to 13. They are 11, 12 years old as an average. In 2016, we had a survey, and we had 0.6% of suicides among the under 11. That's 1 out of 3. One child out of 3 elementary classes. And that shows actually the difference and the development. And this is why it's so important to delve into that question. And why girls? I don't know, actually, and that's why we need to carry out surveys. We need to understand the risk factors. That's the next stage. We need to understand. There were 3 million hospital stays in the previous survey, and we could see that we're reproducing the same trend in terms of suicidal attempts among the young people and the young ladies, the young girls. And when we see the risk factors, there's abuse, physical abuse, sexual abuse committed on young girls. And these are the risk factors that we already know, and we have to continue working on this. These can be environmental, circumstantial risk factors, but also biological risk factors. How about the increase, for instance? What about the COVID effect? Maybe it could be correlated to the prevalence of psychiatric diseases, and we see a primary results that could show the opposite. But for mental anorexia, for instance, we saw an increase. And the question is, the environment, social environment can have an impact, but what about the biological indicator as well? That could be risk factors.
Thank you, Professor Delorme. And you're quite right. Data does suggest that for girls, well, we have data that's quite worrying about the mental health of female teenagers, but we can also see some signals amongst young boys, as shown with the English system and also as mentioned by Mrs. Couto-Magal. There's a growing number of questions being asked by boys. So we study these differences and we just presented the results, the difference, the gaps between the boys and girls, and it's very important to understand them and also to understand how they evolve over time, and we can compare this with the literature. Now over to Caroline Toureau of the National Watchdog for Child Protection, who's going to tell us about the situation of these particularly vulnerable children. Thank you very much. So I work for the Observatoire National, so the National Watchdog for Child Protection, which has been part of the public interest grouping France Protected Children, Enfance Protégée, in order to better prevent and better care for children who are victims of maltreatment. Now, based on the research carried out on children is the extreme vulnerability of children. The results of the research of children in foster care show a high prevalence of overweight, but also underweight, and also speech impediments. As regards the mental health of children, also an excessive vulnerability that was identified in all research, which shows some symptoms of suspected or proved mental health issues. Part of these children have complex psychotraumas, severe behavioral disorders that may be externalized or internalized. Now, several reasons may explain this excessive vulnerability of children in foster care. First, the exposure of a number of acts of violence that are often repeated during the childhood, which may cause or aggravate health problems or lead to chronic diseases amongst these children. And this maltreatment can also have long-term effects and lead to somatic diseases later in life, particularly due to high exposure to stress during childhood, which may cause physical diseases later on. Besides, the institutional treatment, which is fragmented, can have a harmful effect for young people. There may not be enough specialists or supervisors to support and soothe children. So these children who are protected have particularly high needs. This requires some specific counseling and support in a context of child pediatrics that is in distress in France, as we know. Thank you very much for underscoring the specific needs of this child population, which is very vulnerable due to the different factors in exposures that you have just described. I suggest we now move on to the second question that we would like to address, would like to contribute to the answer. So maybe you can tell us about the steps that you have or that your institution has taken to try and tackle this health situation. So over to Dr. Brigitte Moltrecht, who is a doctor and a technical advisor at the General Directorate of School Education in the Ministry of Education, the DG SCO, who's going to be sharing with us the very important steps taken by the Ministry and the experiments carried out in mental health in schools. Thank you very much. Good morning, everybody. So how does the school system contribute to protecting children's mental health? First, we have an overall approach. We have a framework which ensures that children feel well. I'll give you an example. We also have an appropriate healthcare pathway which meets children's needs and avoids we want to make sure that medical services are not stretched. Now, the health crisis has aggravated the situation. There are also uncertainties about peace in Europe, about climate change, the cost of living crisis. In schools, we have a growing number of behavioral disorders, anxieties, eating disorders. And now we can talk more directly about children and adults with these issues, so we can recognize this and we can try to fight and prevent these patterns individually. But we can also choose a positive and systemic approach of mental health by, on the one hand, trying to meet fundamental needs of children and teenagers, such as the need for security and the need to belong. And we can also try to meet fundamental mental health needs in schools by providing a framework and making sure adults support children so that kids can learn, develop their resilience, their coping abilities, to develop their empowerment and autonomy so that they can grow up. In short, to facilitate their development. During the health crisis, the fact that public authorities kept schools open was an important factor, and it probably limited the harmful effects of the crisis, particularly in terms of healthcare. Now, how does it work? People know that if you pass on your own malaise and negative emotions, children will suffer for this. However, children will be attracted or will benefit from individuals who collaborate, who are mindful of the health of children and teenagers. Therefore, adults, of course, members of the family, who are our first reference points, but also adults in the school environment are essential. That's why the Ministry of Education and Youth enshrined the well-being of students, pupils, and staff in its priority plan for the next for the 2021 school year. Also, we have new priorities for the next school year. Train staff in first aid, also including the suicide emergency helpline in children's school textbooks. There are many helpline numbers. And the third measure is the drafting of a mental health protocol in each school to secure the education pathway of children. Of course, these measures are complementary with long-term steps that are meant to strengthen the resilience of children, their psychosocial skills in a conducive environment. And of course, we will continue the organization of national seminars to take into account vulnerabilities, the health pathway right from nursery school. There are other factors for the protection of mental health that are important that should be taken into account, such as physical exercise, taking into account sleeps and other aspects. Sleep needs, excuse me. So this is really a holistic, systemic approach that is being promoted. Let me give you an example. So, Bordeaux Rouge, an elementary or primary school in Toulouse in the south of France with approximately 300 students, pupils, that was extended in 2013. There's a demographic growth in that district. So authorities found that some children presented some symptoms of violent behavior, a feeling of might. They felt almighty. Children who were taken to specialists too late. Also, the lack of communication between doctors and school doctors. So, public authorities decided to set a public health target with the definition of needs, objectives, and steps. A partnership was established with the council, the extracurricular activity organizations, and the high priority schools, preschools, the REP and REP pluses. So, before this project, 2 or 3 cases of violent behavior, etc., were reported per week. Since the project has been established, there has been only 3 reports per annum in the same school. The headmistress found a decline of 40% in violent behavior right from the first year. The mental health of children has been stabilized. Conflict resolution methods are used, rituals and specific educational activities are used, also recreational ones, such as, for example, dances in the schoolyard. Also, some cohesion has been reported, the feeling of empowerment, the quality of relationships with staff, teachers, and also people responsible for extracurricular activities, an improvement of the work environment. Now, we've established this conducive framework to facilitate learning and a good mental health, yet some pupils still need some individual counseling. So, let me now present the optimal health pathway for children in schools. This includes several stages: identification, addressing the different needs. We identified children working with those who see children on a daily basis, educators, teachers. And once they've identified difficulties, as you've said earlier on, they can identify that there's a difficulty, but they may not know exactly what it is. So they get in touch with the doctors, nurses of the national education system, who can conduct an assessment and a diagnosis and will decide whether the child needs some specific treatment or care. So children are referred to an external entity. We try to make children aware of the fact that they need care. We also call the so-called CNP center, for example, if children need to visit a therapist. We then have systems such as the individual treatment system or care system, the PAI, for all types of behaviors, for eating disorders, post-traumatic stresses, etc. Of course, if you want this to be a success, you need to have strong partnerships with child psychiatrists. So some difficulties will probably persist in terms of access to healthcare, but if we do our best to make sure that children and adults feel good at school, and if we ensure that there's a seamless pathway for those who have specific needs, then that means we can meet a number of very specific needs in the school system. Thank you very much, Dr. Fultrecht, for these very practical examples of actions carried out in schools, which reminds us how important the school system is in the development of children and their well-being. Now, over to Dr. Paul Jacquin, who's going to explain to us the part played by Maison des Adolescents and Teenage Centers for the treatment of the children that you receive. Yes, what can we do in terms of prevention? The Maison des Adolescents system was launched in France in 2005, and it's grown in size since then. There are now 120 such centres in France, 3 in the Seine-Saint-Denis department to the north of Paris. What are these centres about? These are centres that can receive youngsters between 11 to 21, sometimes up to 25. They can come with or without an appointment, with or without their parents' authorization. It's very, very important. Otherwise, there's 15 to 20% of these young people that we could not receive, and they come for very different reasons: personal, family-related issues, school-related issues. But it's mainly related to interpersonal difficulties and general malaise. Also, very important point, it's a multidisciplinary team that welcomes them. So there's the educational aspect. We have social workers, educators, often nurses. We also always have psychologists. We have 14 people on our team. We receive about 800 young people every year. Some work on a full-time basis, some on a part-time basis. We have a psychiatrist who works on a part-time basis. And so we also have GPs and psychiatrists. And it's very interesting for a lot of young people who find it very difficult to articulate their mental issues and who also may need physical care. And also there are a lot of questions about the sexual life and identity-related issues. It is basically what the PMI, the Child and Maternity Centres used to do when they had money. A walk-in centre, basically, that answers a lot of different questions. Now, the basic approach is as follows. We receive young people with their requests, with their needs. It's usually a pair of specialists that welcomes them, that bonds with them, that tries to identify difficulties but also resources. And we try to present these tools to young people. So at the first appointment, and over the course of the appointments, we try to liaise with the parents, with the schools. So everyone who is part of the teenage or child's entourage. Now, this is a short duration process. We are the primary level. If in the secondary level you may have children who have depressive symptoms or other symptoms, but we still can do something, and we are required to do it. We are required to support them, but we don't have a lot of resources. So these centres, thanks to this flexible and multidisciplinary environment, managed to handle about 80% of cases that we have to address. Maybe 15 or 20% are referred to psychiatric facilities, and quite often for emergent, so as an emergency. We have the Robert Debré Hospital nearby that takes care of these teenagers. Well, thank you very much for this example of a multidisciplinary approach to deal with teenagers. A lot of actions would deserve some a presentation here, but unfortunately we cannot share all actions taken. However, we believe it's important to highlight all the processes that exist for children and teenagers. Now over to Caroline Toureau, who's going to share these actions with us. Yes. Of course, the issue of mental health of children in foster care is one of the strong priorities of the child protection authorities, and it's been like this for many years. It's not an issue that surfaced in the child protection watchdog during COVID. We had already started a seminar on the mental health of children in foster care, so-called protected children, with Professor Bronsard. About 30 researchers talked about many different issues, identification and definition of disorders, reassessment. We're talking about young, sometimes very young children. So how can you identify these disorders, the epidemiological aspect as well, the effect of maltreatment, also the particularly sensitive periods of before and during and after pregnancies where disorders may appear, particularly amongst mothers. Also other mental health related aspects, or also the consequences of incest on mental health for children and adults who've been victims of that. All the videos will soon be available on the Child Protection Watchdog site, the ONP site. Also in 2022, the government started some work on the health of these protected children. This is in line with the general work carried out by the WHO on health, of course, as was reminded several times this year. And it calls on public authorities to be particularly mindful of health needs, the health needs of protected children. We have the findings of existing research in France and abroad presented on our website. Particularly regarding or taking into account their experience in various institutions, amongst others. So this report that presents different practices that were developed is available on our website. The third action that I'd like to discuss with you today, very briefly, is the seminar. The Child Pediatrics and ASC conference that was organized with the French Society for Psychiatrics. The objective of this first national conference was to go beyond the usual findings about the lack of care, of treatment, and to try to ensure collaboration between these different sectors, to try and put our heads together and improve partnerships between the different sectors. So we organized a number of addresses with pairs of specialists. We had examples from the field. Every time we had someone working in child protection services and someone working in psychiatrics, so they could explain the problems they met in the field, but also solutions to deal with that. Of course, that conference showed the importance of working together by facilitating the development of collaboration spaces between institutions, the need to create a common culture. It was really one of the objectives of that conference. Also, the importance of signing collaboration agreements that govern collaboration, but also that should not be too restrictive in order to be able to take into account the specificities of each young person, but also of regions in order to adapt to the local situation. Also, the importance of some political sponsorship for some initiatives that required a lot of spending, and therefore that needed some political support. Also, the importance of taking care of professionals and specialists who care for children. There was a lot of stress on the support to professionals. All videos of that conference will be available on the ONPE website. The last action that we recently introduced jointly with Santé Publique France was a seminar in March on issues related to the collection of intra-family maltreatment. The objective was to exchange on the challenges of for the collection of data related to maltreatment. Currently, this data comes from various sources, and it only covers part of maltreatment. And it only documents only few of the effects in the short and medium term. This seminar, which was organized by Santé Publique France, allowed us to take stock of available knowledge, but also to identify difficulties that prevent the production of data, for example, ethical and legal difficulties that can be due to the cross-checking of data. Also, the thorny issue of consent, particularly of parents' consent in situations of maltreatment where parents are the abusers. Also, the need to have access to the testimonies of victims. Also, everything related to negligence, which highlights the difficulties of developing data. And particularly if we want to get a full understanding of effects on children. There's very little reliable data today on children in situations of negligence, and this can have a consequence clinically. Of course, there's no doubt as to the severity of this form of maltreatment. It's difficult to produce data because negligence is poorly defined in French law, and it's nearly invisible in standard medical metrics. Besides, negligence is also associated with many other forms of maltreatment. Besides, as part of victims studies that are conducted with adults, it's very difficult for adults to admit that they were victims during their own childhood. And I conclude by saying that programs such as Pegasus, or Protected Health, that could provide complementary data to produce reliable data, are limited by the legal framework, and which causes difficulty for the mining of data. Thank you. Thank you. The minutes of this seminar organized by Santé Publique France, if you could not attend, the minutes will be made publicly available. It was a great opportunity to bring together stakeholders of research, of prevention and health promotion to discuss maltreatment and negligence. Now, without any further ado, I suggest we address the third question, which of course is pivotal. So how can emerging adults, teenagers, be involved in their own health, and what's their perception? So to answer this first issue, how can they be empowered with their own health? So for teenagers or for younger children with the participation of their parents. For this, we're going to listen to Professor Delorme. Well, as demonstrated by Nabi, 13% of children aged between 6 and 11 need access to healthcare. It's likely. And we know that the health and medical and social system is stretched. Now, the question we've asked ourselves is how can we reduce inequalities in access to healthcare? I'm a pediatrician. There are strong inequalities in access to healthcare. So the question we asked ourselves is how can we reduce this gap? Because, you know, all children usually have one or two parents, mostly. Often these children live in isolation, so we need to strengthen parent skills because they are motivated. So we started a system, a website, epsi.fr, a website that provides solutions and tools to parents that they can use very early on. For example, next week we'll be publishing an information sheet to help mothers improve the vocabulary skills of their children, for example, starting to read some things out to them as soon as they were born. How can you deal with defiant behaviors? How can you deal with ADHD? How can you take them to a speech therapist? How can you, or without a speech therapist, how can you improve their speech skills? And same for motor skills. And we know that the improvement of parenting skills usually results in a better support for children, irrespective of their social and economic status. Again, this was our objective. So sometimes we had 20 to 25,000 visits a day during COVID. Now we have about 35,000 visits on our site every month. So clearly parents are very motivated to support their children. I think it's a major priority for public health. How can we support parents? How can we upskill them to support their children? I think that it's very difficult for children to have access to care, particularly mental or psychiatric care. But I think also organizations should change their tack and should think about a shared need for family organizations. And I think that's what Santé Publique France does by working on psychosocial skills. So clearly there's a real priority to support families better with a better organization of care in order to really improve support for each child to, again, reduce inequalities. I think this is a real priority. Also, there's a sheet on supporting children who have suicidal ideas or children who self-harm. Usually, to have access to a specialist, you may have to wait between 12 and 18 months, and you have your child at home who's feeling really bad. So I think it's very important to improve children's psychosocial skills very early on, in school, at home. These are very important challenges for us.
Merci beaucoup.
Thank you very much. Okay, unfortunately we have a tight schedule, so I will suggest now to Mrs. Corton-Magal to present the actions that are to be implemented for the young people. For nearly 30 years now, Fil Santé Jeune has been in existence, and we are really in liaison with you as a continuum of what you do. We work with the educators, parents actually are at the steering committee. We also work with the Ministry of National Education. We thank them for their support. Fil Santé Jeune is in line with the online remote assistance system. It's a hotline as a general sense, because we have different tools. It's available every day, it's 24/7. In terms of telephone, it's from 9 to 11, and online it's from 9 to 11. We're here to actually listen to, speak, reassure, answer, provide advice, but also give some knowledgeable advice. And we have centers everywhere in mainland France and overseas to guide young people. And we also have, for suicidal crisis, we have a protocol to get out of anonymity. A few figures, it's more than 12,000 calls and more 20,000 chats as well. And that actually is taking momentum and to the detriment of online calls, phone calls. We have a lot of phone calls and chats, but we also have chats where they can discuss. We are acting as moderators. There's a website that was completely overhauled, which is very dynamic. We have access via emails with a Q&A kit and a game which is called Abu, Burnout. We also have more than 6 million views a year and 30,000 million views a year for our website. So that covers a lot of 12 to 25-year-old young people. We also have 26 committees from editors-in-chief. We have a lot of current news, a lot of content for the young people, depending upon their questions. Fil Santé Jeune is also a lot of people. They're not robots, they're actually people, professionals, coming from psychological and clinician backgrounds. Very often they're also doctors. They are not judging whom they listen to. They have clinical meetings with a child psychiatrist. They also have practical sessions, annual conferences, and ongoing trainings as well, all year long. As for the educators, that's for the population outlook, for the status of those who call. We're quite well balanced. 22% come from high school, 20% students, and 20% are salaried people. But we also have junior school, which we didn't have before. The main topics addressed are 3 psychological disorders: ill-being, relationship problems, and the body and somatic issues. Thank you for this presentation from Fil Santé Jeune, which is really pivotal for the teenagers and young people, and Santé Publique France relies upon this heavily. To wrap up on this first part of the roundtable, I would like to, before giving the floor to the UNICEF girls, I would like to give the floor to Mrs. Toureau from the UMP. Very quickly, if I manage to say so. We have organized in September with Fantas, we have given the floor to young people, not to have a testimony, but to work on reflection. What is mental health? Was the subject. We had actually very moving sessions because the WHO definition and their definition was quite similar. It was very general. We talked about the extracurricular activities of sports, friends. They also insisted heavily on trust with professionals. so medical secrecy. It's important they need to know who is aware of what they actually disclose to whom. We also need to have peer support. That was actually very much highlighted, and I would like to invite you to actually read what has been written by them. It's very crystal clear. And they talked about their points of view on mental health. That was very useful. Thank you to all of you. We will now give the floor to the UNICEF representatives, the UNICEF Youth Council, and then I hope we'll have the opportunity to have a few Q&As at the end of this presentation. I'm sorry. Unfortunately, we had a lot of questions on the chat. They are very specific. Unfortunately, we won't be able to answer, to have a Q&A session. Well, thank you, Soraya and Aissata, for being here in front of this audience, which is quite impressive. But as you will see, the UNICEF Council is also very impressive itself. So thank you for being here today. Hello, everyone. Thank you for this opportunity given to us to represent the UNICEF Youth Council as well as our measures. I'm 22 years old. I'm an engineer in risk management and environment, and I'm working on energy transition. I've been working for UNICEF for 3 years now, and I'm in the Ocean Committee in Angers. I'm also elected at the National Council of Youth. It is a body which has been in existence since 2019 and which has its second promotion. There are 25 volunteers that are elected on the national, and we have many others on the territorial region. We wanted to have to give a new impetus and to represent the community of young people that are committed to also give a right to participation, which is a fundamental right in the Convention of the Rights of Children. They have the right to give their opinion on issues that concern them and to make sure that this opinion be factored in decision-making processes. I'm going to give the floor to my friend to talk about the strategic decisions that we made in terms of the campaign as well as the tools that we developed. Thank you, Asiata. Hello, everyone. My name is Soraya Divor. I'm a student in defense and security, and I'm also ambassador for Paris Disney for 6 years, and I'm elected at the Youth UNICEF Council. I have been so for 2 years, amongst 23 others. As a young ambassador, we have the possibility to speak about subjects that are dear to our heart in front of you, and this is very important for us. Thank you for your invitation. We want to convey the voice of the youth in an application of the Convention on the Rights of Children. I would like to thank you all, because it's very important to speak alongside specialists and adults. Mental health for the young people is something defended by UNICEF France, but also the international part, because it's very worrying on the international stage, and it's very important to lift taboos and to carry the voice of children wherever they are. Especially in a context such as we have today, we need to make sure that the young people be heard. Our campaign is Lifting Taboos on Mental Health. Our mandate has started in a very specific context with the health crisis. We talked about it. You talked about it as well. This has impacted us all, the adults, but also the young ones. And at the Youth Council, we saw how exhausted we were all. It was necessary then to highlight mental health for the youth and to act concretely, to have actions instigated by the young, for the young people. It was very important for us to meet several times because we come from different regions in mainland France. The headquarters set up workshops, but also weekends where we could discuss without any difficulty and to talk about the situation after COVID. And what we realized is that mental health was the most concerning issue, not only individually but also collectively. It is true that this is not an easy subject. It requires a lot of patience, a lot of reflection, and it is in this framework that all the activities suggested by the headquarters were very successful and allowed us to speak our mind, to speak out on our feelings and how to structure this campaign. We were not all fully acquainted with speaking out, especially when you're young and younger adults. So after 2 years of work, we worked collectively and intensively, and we launched a campaign very recently. This hinges upon some tools, 3 tools. First, awareness raising, that seemed essential to understand the subject with an educational kit. Then we wanted to change our practices with safe zone reflections at school, and also a communication. We wanted to have podcasts. It was essential for us to raise awareness and to lift taboos on mental health and to work and draw upon existing tools. This is why we created our educational kit with 11 to 18-year-old teenagers. We worked with ambassadors but also with professionals or educational stakeholders in high schools or junior schools. It was important to have an awareness raising tool. There was someone that existed already that was actually worked with Pixicom, and the aim was to delve into the mental health issue with the young people. It was created by the UNICEF Youth Council that followed actually the same logic. The aim was to inform the youth on mental health, to realize the importance of their feelings, to speak out when they feel ill at ease, to express their opinions. This kit was thought out to be more inclusive, more dynamic, and to teach more, to give more opinion, to be as interactive as possible with a pack of cards, with some resource and challenge cards to teach children and young people how to take care of themselves. I'm now going to give the floor to my friend. We also had a reflection on how to improve mental health of children and youth at school, especially because this is where they most are. We worked on safe zones. These are actually zones that are important for everyone to know where all the kits and the tools are being available, to know all the processes to follow in case of necessity. The objective also was to create several activities such as conferences but also debates with the youth so that they can speak out on mental health, to make it legitimate but also visible so as to avoid any stigma. To reach our goals, we actually improved our communication tools such as a podcast. We actually created them with 2 VIPs, the actors Loca Devi and Soprano, the singer. And we worked on how to manage emotions and how to improve self-esteem and self-confidence. That is very important for us. It was very interesting to have the feedback as VIPs, because at one point in their lives they had also the same problems and same questions, and they managed to find the answers. These interviews took place with other members of the Youth Council from UNICEF, and the podcast was published in April on the World Mental Health Day. It was important to show to the world the campaign that we launched on mental health. This is an issue that is very important for us from an individual but also collective point of view. We'll show you the trailer of the podcast.
La musique m'a amené une confiance en moi.
J'ai besoin, moi, d'extérioriser ce que je ressens.
Dans mes chansons, on entend mes doutes, mais sur scène, on voit ma confiance en moi.
Comment on fait quand on est seul à gérer nos émotions? Heureusement que j'en parlais, quoi. Je sais pas ce que je serais devenue. C'est horrible de garder des trucs pour soi.
Nous sommes tous des êtres humains, on a des moments de nous, on a des moments très forts.
Il y a certaines situations où on encaisse des choses et on ne devrait pas.
Vraiment, il faut tout le temps, dès qu'on est mal, qu'on est triste, même quand on est heureux, peu importe, comprendre pourquoi.
Exprimer ce qui nous bloque pour pouvoir avancer.
Les monomots est une création UNICEF France et les mots bleus, animés par le Conseil UNICEF des jeunes. À découvrir très prochainement sur toutes les plateformes d'écoute.
Merci beaucoup.
Thank you, Soraya and Aissata, for this presentation on this campaign. I really invite you to listen to this podcast. It lasts 30 minutes, and the trailer actually is a good foretaste of the gist of this podcast. We have influencers that share their own experiences, and that shows that even well-known people like those that you have invited on your podcast had encountered difficulties, because mental health is actually everyone's business. I'm going to give the floor to Patricia to wrap up. I'll do it quickly because we have a bit of pressure in terms of schedule. This is why we feel frustrated in terms of Q&A. But thank you to all the attendants. I would like to thank the speakers, because this is actually eye-triggering, eye-opening data. Thank you to the UNICEF representatives. You said that it was important for you, but it was also essential for us to have you among us. I can see that optimism is compulsory for adults. There are actions. There's a lot of rallying around the subject. Our duty is to be optimistic for the mental health of children, and it's our responsibility. I would also like to mention that there are two other sessions on mental health that could be interesting to you. To promote mental health, that will take place this afternoon. There's a session on psychosocial skills that will take place tomorrow. So 3 important highlights on this topic. There are questions also on the pad that will be disclosed to all of you. You'll have the answers to your questions. We'll be very vigilant about that all questions be answered. And from a logistics point of view, we resume at 2 o'clock. There will be coffee at 1:15, and you will have the opportunity to discuss informally, off the record if you want. And thank you to all of you, and we'll see you very soon. Thank you.